Hi, Jenny Jennings. I'm one of the nurse practitioners in vascularology, and today I'm going to talk to you about acute stroke care. Going to be to discuss the new types of stroke and their etiology. We'll talk about treatment options for ischemic stroke, intracerebral hemorrhage, and subarachnoid hemorrhage, and we'll finish up with the golden hour of stroke care. First, talking about stroke in general. So, approximately 6.6 million Americans have had a stroke. About 1,000 people are going to experience a new or a recurrent stroke. Majorities are first attacks, but 185,000 people that have already had a stroke will have another stroke. The majority of strokes are ischemic strokes with 87%, and the remainder are our hemorrhage population with 10% as intracerebral hemorrhages and 3% as subarachnoid hemorrhages. Approximately every 4 seconds, somebody in the U.S. is going to have a stroke, and about every 4 minutes, someone's going to die. When I do stroke, I can say that it was the third leading cause of death in the United States. Over time, we've gotten much better at preventing complications and giving the patient the best opportunity to improve. So we've moved up in the world. So stroke is now the 5th leading cause of death. The number 1 cause for long-term disability in the United States. More men die each year of stroke, and we are unfortunate to be part of the stroke belt. So if you look at this picture here, there's a large population of stroke occurring, in the area, and Louisiana is one of them. So this has been termed the stroke belt. Factors, we put them into 2 classifications. So the non-modifiable causes of stroke, we can't do a whole lot, but the modifiable risk factors are the ones that we really focus our attention. So if we get through the acute process, then we start looking at how we're going to prevent this in the future. These are the things that we focus our attention heavily on. When we talk symptoms of stroke, usually we're talking about a sudden onset of symptoms. And they're usually negative symptoms, meaning it's a loss of something. So numbness or weakness, so inability to move or feel normally, not being able to understand properly or to speak properly, lose vision or double vision in the eyes, trouble walking, dizziness, loss of balance, or a sudden severe headache. But typically these are going to be sudden, so usually the patient is normal and then suddenly not normal. Unfortunately, unless somebody is with the patient and recognizes, they'll be more challenging to figure out. Types of stroke are ischemic stroke and hemorrhagic, and we're going to talk in more detail about both of these. When we talk about ischemic stroke, we're really talking about loss of blood flow to an area of the brain for whatever reason. And so it could be a thrombotic stroke where you have and plaque formation into the artery, and then it ruptures, causing a clot in the area, and suddenly the vessel is occluded, blocking that blood flow and blocking oxygen to that brain tissue. Or you have an embolic stroke where you have a piece of clot that breaks off from a larger vessel and travels to a smaller vessel. Or you can have something like atrial fibrillation where you develop a clot in the heart and that breaks off and travels into the brain. Talk about our hemorrhagic population. There are 2 major: intracerebral hemorrhage, which is bleeding into the brain tissue, and is usually caused by hypertension. There are some other causes. Usually hypertension seems to be the number 1 cause. And then we have subarachnoid hemorrhage, which this is usually the rupture of an aneurysm into the space between the brain and the skull. So we'll talk more about each one of these. So a bit more about ischemic stroke. Like I said, you can have thrombotic or embolic, and there's also another term that we use is lacunar. And so thrombotic again is a plaque formation that occludes the vessel, and then embolic is a clot from another area that travels into the brain. We have lacunar, which is also called small vessels. So a small vessel stroke is a lacunar stroke, and that's really talking about those vessels that branch off from the larger arteries in our brain. So the middle cerebral artery is a large vessel, but you have these vessels that are going to come off of that vessel to form smaller vessels, and those can easily be damaged with things like high blood pressure, diabetes, high cholesterol, which unfortunately unfortunately, is of our patient population that are coming in. We can also have ischemic strokes due to low blood pressure or heart failure because the pump is not working properly, meaning oxygen is not going to get to the farthest reaches of the brain. So you can see strokes occur because of this, and also loss of blood, which is the same reason. Oxygen is not able to get to the brain tissue. A little bit more about thrombotic stroke. I think I've explained well enough, but this is a nice picture of showing what happens. So over time, we will have called plaque buildup into the artery, and then that plaque can rupture, and it sends signals to the body, of course, and just any injury that we have, we want to stop the leak. It develops a blood clot in that area, and as the blood clot continues to grow to prevent that plaque, you can get this sudden occlusion of the vessel where blood can't get through. So that's what that picture is depicting. And like I said, it can go from either a large artery, like the carotid artery, where a plaque formation has occurred, it ruptured, and clot has come to that area and built up, and then it breaks apart and then travels up through the internal carotid and then can go into the middle cerebral artery or the anterior cerebral artery. And there are some cases where some other weird things can occur, but that's the majority of what we see from the carotid artery. And we can also have atrial fibrillation, which is probably the #1 cause of most of the embolic strokes that we're seeing, is that patient develops paroxysmal atrial fibrillation. They really don't have a clue that this is occurring to them because they're pretty asymptomatic. Unfortunately, that happens. They're unaware. The clot forms in their heart, and then when they go into a normal rhythm, that can then be thrown from the heart and travel up into the brain. And depending on how large of a clot will determine where it ends up getting lodged and what kind of stroke that patient might have. And like this picture showing the smaller vessels, so the lenticular striate arteries come off of the middle cerebral artery. They're tiny little perforators that come off. And so over time, with high blood pressure, diabetes, high cholesterol, all these vascular diseases, those vessels can become damaged, and then when they no longer can allow blood to pass through, we have these small vessel strokes. So we'll talk a little bit more about the small vessel strokes in other lectures, and the large vessel strokes as well. TIA in here because in our organization at Ochsner Jefferson Highway in New Orleans, we don't differentiate a TIA from a stroke, meaning if they present to the hospital with symptoms, they are treated as a stroke. If they come to the hospital and their symptoms have resolved, we still admit them as a stroke. We still work them up in the same way as if they had symptoms, because a TIA really is a warning sign. So 30 to 50% of patients that we will say had a TIA actually will have a stroke on imaging. So we want to dismiss this type of patient, and we really want to take them serious and ensure that we're giving them the same attention. Just some other things about TIAs as a warning sign. So the risk of stroke the day of the TIA is about 17%. So you really want to make sure that you don't just put these people in a corner and not really concerned. You treat them when they present to your hospital as an acute stroke until proven otherwise. 40% of the patients will have had a TIA within 1 week of the event. And so sometimes patients don't always recognize those moments of ability to do something. They usually just ignore it, unfortunately. But these are things that we want to investigate through our history is, did they have anything that happened in the recent days to weeks that would indicate that this might be a warning sign of their stroke. So what's goals for an ischemic stroke? Differentiate the way we treat ischemic stroke versus the way that we treat hemorrhagic stroke. So we'll start with ischemic. So when we talk about what the definition of an ischemic stroke is the lack of blood flow to a particular vessel. So our goal would be to open that vessel and get more blood flowing to the brain and ultimately oxygen to that tissue. And so what we're trying to get to is what we call the penumbra. And this is an area of at-risk tissue, but it's viable, meaning you have a core area of tissue that may have died at this point from lack of oxygen. But all of that tissue around the core is at risk because not getting blood flow through the normal vessel have good collateral circulation, so the blood vessels around the area are bringing in enough oxygen to support that tissue, but that might be just a temporary. So how long that actually is going to last, we have no idea of knowing individually for each patient. So that's why we do what we do, and we do it as quickly as we can, because as we are each step, time is passing, which means brain cells are dying. So we really do want to have a sense of urgency getting these patients in and treated as quickly as possible. This of the penumbra. So when we talk about, the infarct versus the penumbra, so the first scan is telling you what the initial insult might be. So that little tiny red area is the core infarct. That's the dead tissue, which we can't do anything about. But all the green tissue is potential salvageable tissue, meaning if we can and we open that, whether we use TPA or we do endovascular therapy, that area of tissue can be salvaged. But you can see as time goes on, more and more of that tissue will die, and ultimately, if not treated, the slide in picture 4 there is going to be what the patient is left with. In blood management, we do treat blood pressure very differently in our ischemic population and in our hemorrhage population. So with an ischemic stroke, we tend to let the blood pressure rise pretty significantly. Now, the types of stroke will determine how the body responds. So meaning if you have a sudden occlusion of a vessel, you sometimes don't get the spike in blood pressure initially because the body has not recognized as quickly because this is such a sudden event. Versus if you have a vessel that's occluding over time, you tend to get the blood pressure rising pretty dramatically because it's trying to compensate over the lack of blood flowing to potential areas of brain. So a lot of times we are not going to treat the blood pressure. We're going to allow it to rise up to compensate for the tissue that is at risk. And now the difference is when we start talking about treating with TPA, there is a big, huge difference about how we can give TPA with blood pressure. So lowering the blood pressure can cause decrease in perfusion pressure, which means that not enough blood is going to get to the brain, which can extend the infarct, versus if you have too high of pressure, obviously all of that tissue that's just died is very fragile and can start rupturing and bleeding into the brain. So it's a fine line of where we want to be, and the good thing is we have studies out there that help guide us. There is number, some magical number that we know for sure, but we do after about 220 over 110 is really where we start wanting to treat blood pressure. Otherwise, we let that rise. And like I said, we're going to give TPA, and then we want to lower that because and TPA puts tissue at risk. And we'll talk more about that. Different options that we have when somebody comes in with a stroke. Now, again, we're talking about the acute stroke, not just someone coming in with a stroke that's several days old. We're talking about a patient who presents in a 12-hour window with symptoms suspicious of a stroke. So we can do TPA, IV TPA, and this is a thrombolytic drug that has been shown to lyse up the clot to allow blood to flow. There are very strict guidelines as to inclusion and exclusion criteria that have to be met before this medication can be given. Not everyone is going to be eligible. Also have endovascular procedures where we can go into the vasculature and remove the clot mechanically. So we have a couple of different devices that we use to do that. And then unfortunately, if the patient is not eligible for either one of these two treatments, then we do medical management. And so that's really focused on the etiology of their stroke and trying to have secondary stroke prevention while they're in the hospital and then discharge. Also place or TPA. It is currently the only FDA-approved medication for the treatment of ischemic strokes. They do have to be screened and meet inclusion and exclusion criteria. There's another study that came out after the original studies that extended the window from 3 hours to 4 hours, but that is only for a particular subset of patients. Not everyone will be eligible for that. So the neurologist, in combination with the emergency room physician and the nursing staff and everyone, the family involved, will discuss the potential risks, benefits of this medication, and hopefully this is something that we can give to the patient. Unfortunately, 3 to 5% of those patients have a stroke reach the hospital in time, and we can see that time and time again in our own organization where the patients just didn't come in enough time, and by the time they're getting to us, we're limited in how much we can do for them. Now, talk about large vessel and small vessel. There are differences. So if you have a large vessel occlusion, meaning you're going to have a very large clot burden. So the clot is going to be a pretty significant size. If you give TPA and you get IV, it is going to go all around the body, and only a part of that TPA actually gets to the clot. It's only going to affect the areas it can reach. So if it can only get to the front part of the clot, then the back part of the clot is not going to be dissolved. And so there's a stronger chance that a large vessel occlusion is not going to see significant improvement with TPA. So when we think about these types of patients, these are going to be patients that we then want to consider for endovascular procedures because they're more likely to have success where we mechanically remove the clot. And we've actually been very fortunate to see some really great outcomes in our population. It's not for everyone, obviously. You have to have salvageable tissue to go in because reusing dead tissue doesn't really do any good for that patient, and it can actually cause harm. So we do have to, again, inclusion, exclusion, risk versus benefit, and talk through those things to make sure that we're selecting the right patient. Large vessel occlusions are really talking about the internal carotid artery, the middle cerebral artery, the anterior cerebral artery, vertebral and basilar arteries. So that is the nerve vessels, and so depending on where in those arteries will determine if they're eligible. We'll never exclude a patient from TPA. We're always going to give them that opportunity of TPA if they're eligible for it. But then we found as TPA with mechanical thrombectomy is actually leading to more complete reperfusion, improved early neurologic recovery. When we measure outcomes for stroke, we look at what we call a modified Rankin score, and we look at that at 3 months. So we look at patients at 3 months to see how well they're doing, and we grade that with a modified Rankin score. So we want 0 would be no symptoms all, and then of course, as you go up into the number, 5 is a patient who's really bedbound, requires full nursing care, and so we gauge those patients based on that scale. All right, so we'll move from ischemic strokes and start talking about intracerebral hemorrhages. And so again, this is kind of a big term, but it's broken into 2 different types of hemorrhages. So intracranial hemorrhage is a general term that's used for all bleeding into the cranium. Intracerebral hemorrhage is really focused on bleeding that is in the brain tissue. And we're talking about spontaneous intracerebral hemorrhage versus a traumatic event. So we're going to take those traumatic patients and not even discuss those because there's a whole different etiology and patho. What we're talking about is those patients that have sudden bleeding in their brain that is non-traumatic. So it's the most common form of stroke, and it's usually smooth and progressive. Not necessarily all the time, because you can have a patient that ruptures and bleeds very dramatically and has a dramatic effect. But we talk about the ischemic population. Usually, when that vessel gets occluded, that is when you're going to get these sudden. So I gauge it necessarily on that statement, but you can see a difference in the progression. One of the deadliest forms of stroke, so you're going to see a large population of patients that are going to die from this. A lot of times the patients don't actually make it to the hospital, so if they do make it, they're coming in pretty bad off. It's an 8% mortality at 6 months. A lot of patients are not going to survive from this, so we make sure that they're getting in early and that we're intervening early so that we can give them the best opportunity for recovery. When we talk about the causes of hemorrhage, I said hypertension is usually one of the major causes for lacunar strokes. It's also a major causes for intracerebral hemorrhage. So if you can imagine someone who has uncontrolled blood pressure that rises, at some point those vessels are not going to be able to tolerate that, and it causes damage to the vessel and eventually rupture. So that's going to be our number one cause, is just a hypertensive emergency that caused an intracerebral hemorrhage. Also have coagulopathies that can cause bleeding, so someone on Coumadin. The NOACs are the new oral anticoagulation drugs like Eliquis and some of the other ones I can't think of right this minute. So rivaroxaban or Eliquis, and then apixaban is Xarelto, excuse me. And I think I got that wrong. So apixaban is Eliquis and rivaroxaban is Xarelto. So those are some of the new drugs that we've started to use over the last couple of years for prevention of atrial fibrillation, or not prevention of complications of stroke with atrial fibrillation. And so either they're concomitant or some of the NOACs that ultimately puts them at higher risk of clotting disorders. Another type of condition is called amyloid angiopathy. And that is it's a protein that deposits in the brain. It's usually in the older population, and you start seeing hemorrhages in areas that are not as typical. So when you see a bleed on CAT scan and it's in a particular area, usually, not always, but usually if it's in one area, you can say, oh, that is a hypertensive area of infarct, versus if it's in another area, you start thinking of other reasons. And amyloid angiopathy, usually you see kind of these lobar infarcts of bleeding into the brain tissue. There are different locations, and that's kind of how you can develop the cause of their bleed is in a lot of times the location. Of course, cocaine, methamphetamine use causes intracerebral hemorrhage, and any kind of vascular malformation can as well. Scan depicting what it looks like, what a hemorrhage would look like on CT. And then a little bit about the management strategy. So our goal obviously is going to prevent any further bleeding. We don't want that bleeding that is in their brain already to expand, and minimize any kind of cerebral ischemia from the pressure that a hematoma can exert and the swelling that occurs as well. So the big thing is going to be lower the blood pressure, manage that blood pressure very, very closely, much different than the way that we look at ischemic stroke. So again, in the ischemic population, we let that blood pressure rise up a little bit, but with the bleeding that occurs from hemorrhagic stroke, that blood pressure is very, very important that we lower it and we manage it very, very closely. We've had patients have really bad outcomes because their pressure goes up and down and it's above goal, and then we bring it down and it shoots back up and it goes. So it really has to be aggressive with the blood pressure treatment and get it down. And one reading is enough to cause a problem. So you want to make sure that every reading you're getting is within your goal. Sometimes we'll use reversal to reverse the anticoagulations they might be on, so vitamin K, FFP, or prothrombin complex concentrate, which is Kcentra. These are things to try to minimize the expansion and the bleeding that might be occurring so that we can stabilize that hemorrhage. We'll move on to arachnoid hemorrhage. So this is, again, bleeding in the brain, but it's not in the same location. So this is really in the subarachnoid space, and it's really where the majority of these are going to be caused by aneurysms. And so we think of aneurysms in areas that have very turbulent blood flow. When we think about areas that have turbulent blood flow, it's usually vessels that turn abruptly. So you're going to have more of that turbulent blood flow. It causes damage to that lining of the vessel and eventually causes an outpouch. And so you get this aneurysm. And eventually, if that turbulent blood flow continues and that aneurysm grows, at some point, not all, but it's so potentially that it can rupture, and that's where you see the subarachnoid bleeding. This patient is going to present very differently than our ischemic stroke or our intracerebral hemorrhage. Usually the subarachnoid is a sudden headache that goes from not being present to being at maximal intensity when it starts. So it's the wake of life, it comes on suddenly, and again, it's at that maximum intensity. And this is when we start thinking if somebody presents in triage with this type of scenario, is you assume the worst, and then you can rule those things out. So with the CAT scan and have a better idea if we think that that's what's going on with the patient or if there's another cause for their acute headache. The patient also has a very high mortality, so 10 to 30% of patients die before they even reach the hospital, and then 30 to 60% who even reach us will end up dying no matter how exhaustive of treatments that we do, unfortunately. Etiology, usually it's going to be that ruptured cerebral aneurysm, so 80% of the non-traumatic subarachnoids, because you can have traumatic, which again, we're not talking in this lecture, really talking about those spontaneous things. So again, aneurysms, and then most occur around the circle of Willis or very near that, or if you have an AV malformation that ruptures, you can get bleeding also in the same area. And this is CT imaging. This is a non-contrast of the head, and you can see all those lighter areas in the subarachnoid space is bleeding. So what management strategies for this population? It's really, again, prevent rebleeding. So typically, just like when we cut ourselves, we have a cut, we bleed, we clot, and it stops bleeding. This occurs hopefully in the brain, if not given a reason to continue to bleed, like high blood pressure or some other things. So eventually that clot will stop and it'll stabilize. But if we don't do the blood pressure management, or in some cases, depending on the location, it may be that, yes, we have to go in and do treatment. So endovascular is probably the choice of treatment for most of these aneurysms because it's the least invasive, still invasive, but least. And what that is we just go in and we place coils into the aneurysm itself, and fluid wants to flow in an area that's easy to get to. So if you have high resistance into going into an area, then it's going to avoid that. So that's the concept of putting coils into that aneurysm, so then it's kind of blocked off and blood doesn't want to go in there and it just wants to travel forward without any problem. So that's one way of treating it. And then obviously surgical intervention where we go in and clip, which is much more invasive, which has much more complications, but that is more of a definitive treatment plan for an aneurysm. And then there are some aneurysms, when we look at how we can treat an aneurysm, it really has a lot to do with the neck and the location and which route or which the best way to take care of that aneurysm. And so that's a discussion that is done with the neuroradiologists and the neurosurgeons to kind of see what would be the best approach for the particular patient in that particular aneurysm. We definitely that we're managing blood pressure and vasospasm and the strategies for subarachnoid hemorrhage. So we see a lot of focal changes in these patients. Spasm can occur in up to 50% of the patients. There's a timeline as far as, it peaks around day 7 and can continue up to day 21. So there are things that we do in the neurocritical care environment to try to reduce the likelihood of vasospasm. Again, reduce doesn't eliminate, and I apologize, nimodipine is spelled incorrectly there. It's Nimodipine. But nimodipine is a calcium channel blocker that has been shown to prevent vasospasm. So that is one of the interventions that we do. If the patient does start to have vasospasm, they have to take that patient to angiography and do angioplasty to open up the vessel. Sometimes they also use verapamil IA, which is intraarterial, to help open up that vessel. Because if you can imagine you have hemorrhage and you have other vessels that are spasming, and so they're clamping down, not allowing blood flow to get to the other parts of the brain. If that happens and you don't intervene, now not only are you going to have a hemorrhagic stroke, you're now going to have an ischemic stroke because of the vasospasm. So it can be very serious. And we do daily TCDs in the neurocritical care and some other interventions to try to minimize the fact that that might happen. So now about treatment. So when we talk about the patient coming into the emergency department, whether they drove themselves or whether they came in by EMS, it should be the same approach. Time is brain. And we talk about, if the longer we take for each step, the brain cells that are affected. So it is one of the most crucial factors in the outcome of stroke. Many studies show the earlier TPA is given, the better the outcome. You can give it in a 3-hour window. If I'm having a stroke, I would prefer to get it in the first 45 minutes of my symptoms versus the last 45 minutes of the window. So you want to push to try to move things as quickly as possible so that we can give them the treatment as quickly as possible. So 2 million brain cells die every minute. So if you can imagine how many brain cells are dying as we're doing all of these interventions, trying to get to CT, trying to get them back into the room. So we try to minimize the time as much as possible, and this is right here. So each hour we fail to treat the patient, they lose as many neurons as it does in 3.6 years of normal aging. So that is a lot of brain cells to lose. Our goal and our job as healthcare providers is to prevent as many neurons dying as possible. So the goal is to give TPA in less than 60 minutes, but again, I would rather have it sooner than later. I'm sure most stroke patients would agree with that as well. So there's obviously different people that are involved in the activation. So we'd really love if families and patients would dial 911 to get the patients here versus driving themselves. Again, lots of studies that show better outcomes if people call 911 and they get treated. We can do pre-arrival notifications, so they call, they let us know, we can have the team readily available and start getting everything rolling versus somebody coming in the front door through their own car. They go through this and that, and it just takes longer. Even when we do it quickly, it's still longer. So pre-hospital, 911, EMS involved. We have the transfer services, so if patients go to a smaller hospital and they are unable to give TPA, we want them to go to a larger hospital. We really don't even want them going to that hospital. We want them bypassed. We'll have flight care that can transfer patients as well. We have telemedicine, so if a patient is at another hospital that doesn't have a neurologist on site, we can offer telemedicine and give that opportunity for a stroke doctor to evaluate the patient, and that's in collaboration with the transfer center. And then, of course, our emergency department. So we have our nurses, our physicians, we have our radiology department. The secretaries play a role in our ED registration. So everybody has to come together to recognize that this is a stroke and we need to act very quickly. With an hour of stroke, this is what we're talking about. And so each step should occur in a very succinct way. So the patient comes in, gets triaged. That ER physician should be seeing that patient within 10 minutes. That ER physician should recognize that, yes, this is a stroke, and they should be activating the stroke team. Stroke team should be involved as quickly as possible. In the meantime, patient is being wrapped up and packaged to go to CAT scan. That is the most important step at this point. So when we are at CAT scan, really what we're looking for is to rule out hemorrhage as the cause of their stroke. It's the only thing that we're really looking at. Shouldn't say the only thing. If there's something obvious, then yes. But really we're looking to see if there's bleeding on the CT, that automatically excludes them from TPA. So we want to know that, because if we get that, we can move forward to the next step. So CAT scan should happen within 25 minutes. Within 5 minutes or less, really less, we would prefer, we have that CT result available. We have our lab results as needed, meaning if they are on warfarin, we need to know their INR. If they have a platelet issue, we need to know their platelets. So we'll be able to get those labs that are pertinent to making a decision to treat back in enough time that we still are within that window. Most of our patients are going to get an EKG very quickly to rule out, even if the patient is having a heart attack, if they're having a stroke, a heart attack, we're not going to not treat the stroke. We're still going forward and treat the stroke. We'll consult with cardiology and figure out everything together, but ultimately we're still going to continue to move forward. Chest X-ray is important if it's for the decision to treat. We still need to be able to show that we can do that within 45 minutes of the patient's arrival. In 55 minutes, you need to have the decision to treat. So obviously this is coming from the vascular neurologist in collaboration with the ER physician, but as the nurse at the bedside, you need to be anticipating that this is going to be a TPA patient. Make sure you pull the TPA. You never do anything like that without the order and scanning it, but you want to have the pump available. You want to have all of it available. So as soon as you get the green light to go forward, you spike it, mix it, and hang it. And then, of course, the goal is within 60 minutes, a door-to-needle time. If we give off any time so that we push this back to less time, that would be ideal. We should absolutely not be exceeding the 60-minute mark. So if you're the nurse on the floor and identifying this patient as having symptoms, you need to quickly identify and assess the patient. Your goal is trying to establish the onset of symptoms. When were they last known well? Sometimes that's the same time. Sometimes it's a little different. Fortunately, if they went to sleep and then awoke with symptoms, we can't get onset time. We have to use their last known well. Acute stroke patients, when they come through the emergency department, they should be triaged at the same level of acuity as an acute MI or some sort of serious trauma. This is a patient who is ultimately losing brain cells. So there's no such thing as an acute mild stroke. It's always a severe stroke that needs intervention until proven otherwise. So again, all strokes are severe until they're fully assessed. At a point, once the emergency room physician goes into the room or the vascular neurologist gets involved, that patient can be downgraded and you can stop that acute stroke process, but you never want to make that assumption until they've been fully evaluated. All strokes whether it's an ischemic stroke or a hemorrhagic stroke, can rapidly decline very quickly. So you need to be monitoring these patients very, very closely. And a stroke code should be initiated. So anytime a patient presents to your emergency department with symptoms of which you think might be a stroke or TIA, within 12 hours of a symptom onset, they should be put to that acute stroke code bucket, and the process should immediately start. At Jeff Highway in New Orleans, we do an overhead page to try to expedite. It gives a sense of urgency. People start moving around. We have also our secretary who makes some phone calls. So whichever way works for you to make it happen with the emergency department, that's what you need to do to have all the players in place moving very rapidly, everybody understanding what their role is in this process. We talked about the symptoms, but again, this is all types of things that we see when we have patients come in. It's really that sudden onset negative symptoms, so they lose the ability to do something is typically what we see. One I want to point out that sometimes is overlooked is the loss of vision. So our occipital lobe is where our vision centers are located. And if you have a stroke in just your vision center, that is the only symptom you're going to present with. It will be a sudden loss of vision. And that patient may describe it as blurry vision, double vision. It may be an assortment of different ways, but you need to tease out, is this a sudden? If it is a sudden loss of vision, you want to activate a stroke code. You can get ophthalmology involved at the same time if you really think that it might be an eye issue, but more than likely acute sudden loss of vision with no prior history is more than likely going to be a stroke. So don't overlook that as a symptom of stroke. CT scan, and again, we're really trying to get this as quickly as possible so that we can rule out hemorrhage as the cause of the stroke. If possible, that patient should go straight from wherever they come in, whether it's triage or the EMS, right to the CT scanner to start that process. If they can't go there for whatever reason and they go to an ED bed, you really do not want to extend the window for CT to do other things. If you can get them, if you need to start an IV and you can do it very quickly, or you need to draw blood very quickly, but as soon as radiology is ready for that patient, you should allow that patient to go into the CT scanner. You can continue to work while they're in the CT scanner getting the patient ready to scan, and then ultimately when you get back into the room. The goal door to CT is less than 25 minutes, interpretation is less than 45. In the room, they get their CAT scan, or you're about to get them. So the first thing we want to do is make sure that we repeat the glucose and iStat if it's available. So now hospitals are able to do this. At Jeff Highway, we use the iStat to do a point-of-care creatinine and a point-of-care INR. If we're not able to do the 45-minute turnaround for labs, so if you're in a hospital that your volume of labs may not be as high, your laboratory might be able to do things much faster than what we were able to do at Jeff Highway. So what works for you is what really needs to happen. And you only need to get you don't need any labs to make the decision to treat unless they're clinically indicated. I mean, if you suspect this is a diabetic, this could be a glucose issue, yes, absolutely you should check the glucose. But it's a simple thing that we're used to doing in kind of that acute setting. So doing an AccuCheck to find out what their blood glucose is, if you can do the iStat if needed. But really, decision to treat is based off of the clinical presentation, their clinical history of problems, and then going from there. So blood work so you can get it started and going. For primary care centers that are certified through the Joint Commission and comprehensive centers as well, we have to show that 45 minutes in order to results. All codes need to remain NPL, and this includes medications. Large percentage of patients that have strokes will have weakness in their swallowing muscles, and so you need to assume that they're going to aspirate until proven otherwise. We do dysphagia screening so that we can ensure that the patient at least has the ability to swallow and before we start giving medications. But if not doing a further evaluation of their swallowing, you shouldn't be giving a diet unless they're screened by speech therapy and clear to have food and have a diet ordered. Obviously, all of these acute things are going to be important. So when we talk about within the first 10 minutes of the patient's arrival, I'm going to have all this known. So when was the last known? Well, when did the symptoms start? Was the stroke alert activated? You want to document that. Physician at the bedside with their capillary blood glucose, and then documenting their IV IVs placed. And within the first 15 minutes, you want to complete an NIH or a modified version of the NIH. You don't want to delay CT again. So the goal is get to CT. If in a hospital that does not have vascular neurology on site and you're going to do telestroke, you want to document the telestroke consult was ordered, what time the cart was at the bedside, when was the phone call placed to the regional referral center, and who's the neurologist that's getting on, so you can have all of this information readily available. A lot of times this is data that your organization is going to want to know to see when there's a delay in care, where did that delay occur, and so this helps you know where in the process it broke. Chart everything. So we don't know what's happening to the patient if we haven't charted it. So I think it's pretty clear. These are things that we're doing. So if it's not in the chart clearly, we have to try to figure out when these things are happening. So make sure you're including that in your documentation. That was put together to discuss TPA, and it really goes into good detail about the inclusion criteria, the exclusion criteria, and just some pharmacokinetics about the drug itself, how to dose it and calculate it, and then all of the monitoring. So as a bedside nurse, if you're taking care of a patient who just received TPA, it is going to be a one-on-one patient for an extended period of time, because you're doing Q15-minute vital signs and neuro assessment. So you're actually having to check their neuro assessment very frequently after the TPA, and you're looking for changes that may occur. So if you have a patient that is changing and problems are occurring, you need to assume that this might be an expansion or bleeding into the brain from the TPA, and so you need to stop the TPA. They need to go to CAT scan and figure out, is this a bleed, or if this is something else going on. Sometimes what can happen is they might start to work. You might get some better flow to the vessel, and then it reoccludes and you get worsening symptoms. So that is a possibility. So just because the patient worsens doesn't automatically mean they're bleeding in their brain. Sometimes it could be that that vessel that was partially open is now occluded completely and the symptoms are worse. But stop TPA, give them to CAT scan, and then once they are clear that this is not a hemorrhage, you can restart the TPA. This is something that we use, and it's really just to help make sure that the patient's getting the right dose. So this is, alert medication. It should be treated as such, meaning it should be verified with the dose. So just because the physician gives you a dose, you really should know how to calculate the dose, so that you can ensure that what the physician is telling you is the appropriate dose is in fact the appropriate dose, and that two registered nurses are verifying that, yep, this is the correct dose, and then it talks through the administration. And TPA is a fairly easy medication to administer. It does come as a bolus, and then the remainder is given as an infusion over 60 minutes. So there are processes in place that you should do to ensure safety of this medication. I believe that's going to be in another lecture as well. A minute on the studies that we do in stroke, because we do quite a few different things, and some patients get one thing and not the other. So it might be helpful to explain a little bit, just to level things about what we do and why we do. So we talk about the CT initially, that 25-minute CT. That is what we call a non-contrast CAT scan. It really is to rule out any obvious hemorrhage. Sometimes you can see changes in the non-contrast CT, but typically you're not going to see that for several hours to even days. So it's really not diagnose a stroke. So if someone says, oh, the CT didn't show any stroke, that's not exactly the right words to use. You can say the CT didn't show any bleeding, and that would be a more appropriate assessment of the CAT scan. A TA is a CT angiogram. So what we're doing is we're looking at the vessels and looking to see if there's any occlusion in those vessels, and we can do that very quickly in the emergency room as well. The contraindication for this is somebody has pretty significant renal dysfunction. We meditate. It just depends. Again, we talk about risk-benefit, and everything we do in medicine is risk-benefit. So if benefit is to get this CT angiogram to potentially go to another procedure, and maybe their kidney functions aren't going to be the highest priority. It just depends. We individualize it if the patient has renal dysfunction and make those decisions at that time. A CT fusion is really looking at the tissue. And so what it's trying to do is kind of give us an idea of how much penumbra tissue, that area of at-risk tissue, how much is there. So if you have a patient who had a stroke and they have a very large core infarct, and CT perfusion will pick that up, and that is not a patient that's going to be benefiting from a endovascular procedure. So we don't take every patient to have a thrombectomy. We are selective. They do have to still fit criteria, and the CT perfusion allows that decision to be made. Obviously, we use our ultrasound, so we do a carotid ultrasound on patients, and we're looking at how patent those arteries are. And usually we do CTA, CT perfusion more in that acute phase because of the timeliness. We can get that very rapidly, where MRI takes more time. We can do very similar studies that we do with the CTs as in the MR population as well. So MRI initially, it's not as great as identifying blood in that non-contrast CT, so that's really why we use the non-contrast, but it does give us a more information of the tissue and what area of the brain may have been affected early on. And then an MRI is very similar to a CTA. It gives us visualization of those cerebral arteries. Again, we can't do MRI if the patient has a pacemaker, so we may be limited in that respect. So please direct any questions. There's my information if you need to get in touch with me, and I appreciate your attention. Thank you.